So surgery, right? So we need to go to surgery, make sure they cut that area out, right? Okay, so what else can we do? We need to prevent constipation because that pressure is what pops it out, right? Speaking of pressure and popping out, what's another problem that happens with pressure?
Hemorrhoids.
Hemorrhoids, yes. Well, ICP too, but that's more like you don't want the pressure to increase so that it doesn't affect other issues, But more likely, I was talking about the hernias. Yeah. Okay. So what's a hernia that boys get? Inguinal hernia. Yeah. Inguinal hernia. Yeah, inguinal. Sorry. Okay. So let's say a person has any kind of surgery, abdominal surgery, whether it was the colostomy or whatever they need to resection this, whatever. What are some interventions that we should do for them that has to do with the surgery that we haven't mentioned? So a person has abdominal surgery. What are some interventions that we should do after the surgery to make sure that they thrive?
Coughing.
Yes. So what do we do with the coughing? Splinting or binder, right? To hold it in place so it doesn't hurt, right? If they're coughing, that kind of thing. If there's anything with dehiscence too. Small, frequent meals, right? What else? Say it again. Stool softeners, yes, that's very good. Yep. All right. So here are some charts that can help you distinguish between the chronic or gastric, duodenal or gastric ulcer. I just put the chart there. Another chart that helps you distinguish between Crohn's and ulcerative colitis. Now, bowel obstruction. Usually it's bowel obstruction that leads mostly into the colostomies that are going to be permanent. The others, after they do the anastomosis, it heals, they can sometimes, put it back in and, do what they have to do. Not all the time, but sometimes. But usually with bowel obstruction, they definitely are going to have a colostomy. I know my nephew, which one did he have? I think colitis. And so he had a surgery done. They cut a little piece out, and he didn't have a colostomy. So it's not all of them that will have a colostomy, but the bowel obstruction, they might definitely have a colostomy in there. Okay. So let's see. How would we know they have a bowel obstruction? The pain, the distension. Yep. Mm-hmm. So absent bowel sounds, definitely. Okay. Maybe vomiting. Okay. That's a cause. If we know that they're on narcotics, then we can have that hypervigilance to say, there's possibility that might be a reason. Now, here's the thing that, that was exactly what I was about to say, Justine, yeah. So sometimes it backs up so much that the feces starts to come out their mouth. So that's a huge no-no. We need to get them help, right? We definitely want to do antibiotics. We want to do the nasogastric tube at that time, the TPN, all the things we talked about, right? Colostomy, kind of mentioned it already. We're looking at the stoma. We're looking at the surrounding tissue. We're taking care, the self-care. How do we know the person is ready to do self-care? As opposed to, yeah, right. They've accepted. They're looking. They're watching. They're asking questions. But if they don't look at it, they look away, or they tell you somebody else is going to do it, then their body image is not good, and they're not going to take care of it. You need to get them someone to help them. Right? That's a skin integrity issue. Let's now go into cirrhosis. Okay. Usually, what causes cirrhosis? Alcoholism, for sure. Right? So it's a destruction of the liver. Right? And there's a scarring that happens. Right? The cause is unclear, but it's mostly seen in people who are alcoholic, right? So there's so many different purposes of the liver, and when this thing happens, it's a big problem. And a lot of times they don't get back to their normal selves. It's really hard once you destroy the liver to bring that person back to its normal function because the liver did so much. right? So the liver,
Hepatitis too,
what are
right?
some of, hepatitis, exactly, you're right. So what are some of the things the liver does, right? It breaks down albumin, we mentioned that. Breaks down drugs, protein, carbohydrate, fat. It's the one that helps with that. It helps filter, or it stores blood. That's another thing, okay? Okay, how would we be able to tell an early stage or as opposed to late stage of a person who has cirrhosis? Jaundice, tenderness, yeah. So usually the yellowness, the jaundice, the nausea, like the stomach problems is the early sign. The late signs are when now fluid is being backed up into the liver. Then we have the varices, right? The esophageal varices. Remember what that is?
Yeah, it's like putting pressure on the veins that are
Connected
up
to, yes.
here, and so
Right. So when we think about the anatomy, we know the liver has a portal, two arteries that lead from the stomach to the so from the stomach to the liver. The small intestines have arteries that go from the small intestine to the liver. So when the liver is broken and it can't filter in order to go to the kidney, what it does is it backs up from where it came. So when it backs up, it goes back into the small intestine, and the small intestine backs it up into the stomach, and the stomach backs it up into the esophagus, right? And then that's where you have the varices in the esophageal varices, right? So all that portal hypertension is going to cause esophageal varices, right? And so that's a big problem. What's our biggest worry, though? Hemorrhage, right? Those arteries, which are larger now because there's pressure, burst. We have an artery that can't stop bleeding. It's on the inside. We can't just, it's going to keep bleeding. Okay, so we already talked about GI disturbances that might happen, the esophageal varices. Another thing, too, late sign is pruritus. What's pruritus? Itchy, right? Where does the itchiness come from? Right? That's not being broken down, so it's kind of like a salt. Bile salts, and it's going into the skin. So, and that's usually how they test it too. They have this salt test, and they see that if the skin is salty, then they know that there's probably a liver issue. So yes. So, and then we have the clay color stool. That's also a late sign. Portal hypertension, another one. We have the ascites. Ascites can be an early sign, right? That doesn't necessarily have to be a late sign, but I forgot to mention that one. Interventions. What are we going to do? Encourage rest, right? What else? Stop drinking, right? You guys, honestly, I have seen this. I don't know if you've seen this, but I've seen this. I saw once this man who was pouring alcohol down his G-tube. Like, dude, like that. She said commitment. I was like, bro, like, really? What are you doing? Like, I was on the street, like, and it was in the middle of the day. Like, I remember I was on my way to school, and I was like, what is he doing? And then I get to nursing school, I'm like, oh my gosh, that man crazy. Right? But they're so addicted, right? So since we're on the topic of alcoholism, how do we know when a person is an alcoholic? It affects, but day-to-day life, yep. The timing usually, right? They always tell you when they drink before a certain time, then that means they can't do without it. That's one. What about withdrawal, right? The shakiness, they gotta go, they gotta take it, or else they start think of seize, right? And when they go through withdrawal, that's why we have to monitor them very closely, because they can die from a withdrawal because of the seizures and all the other things that come with it, right? Let's see. Okay, so diuretics. Why do we give people with cirrhosis diuretics? What are they pushing out?
They don't have enough protein.
Yeah.
It's like fluids leaking out
Everywhere, right? The interstitial space. And I remember one of my first patients in nursing school was a liver, had cirrhosis, and his legs were weeping. right? What does that mean if it was weeping? Fluid literally dripping down his legs because the interstitial was that full, right? Usually we know, okay, you have edema, then you have pitting edema, but then you get weeping. That's a lot. And he had the ascites, and usually they have like the skinny legs, the big abdomen, right? And so we give the diuretics in order to get rid of that fluid for them. We do the pleurocentesis in order to remove the fluid from the ascites, right? All right. So the bleeding esophageal varices, we kind of talked about that. If they're vomiting blood, that gives us a clue. If they have black tarry stool, it can be that they swallowed some of it and then it ends up in their stool, right? So I just gave the answer. The stool is black because it's digested blood. So the higher up it came, that's why it's dark. The lower it's coming from, it will be red, right? Okay, what else? So severe scarring. So what are some of the problems? We would have the liver scarring. We would have the blood clots, the parasitic. Okay, these are some of the things that would happen. Let's see. Quitting smoke, not smoking, alcohol would be the best way to help this. Okay, let's talk about gallbladder disease. What does our gallbladder do for us? It breaks down the fat, right? Yes. So it helps with breaking down fat. So when our gallbladder is not working, we don't have anything to help break down fat. So how would we know that a person had a gallbladder stone? Pain. It's excruciating. Yes. That right shoulder pain. Okay. And what would they have to do? Surgeries, right? So before, it starts with like tenderness or some discomfort, some nausea, a little bit of pain, and when they evaluate it, if it's not excruciating, they'll tell them to change their diet, right? To watch what they eat. When they tell them to change their diet, what kinds of foods are they telling them to stay away from? Fatty food, high cholesterol type foods, so greasy foods, fast foods, those kind of things, and they're possibly able to manage it. But then if they're not able to, then they go into surgery. I actually knew a coworker that passed away, and she had the issue. I remember she was at work, she was feeling pain, she went to the doctors, and they were like, it wasn't too bad, it was just uncomfortable. They sent her home, and then in the process of being home, she passed away, and it's like, what the heck happened? But yeah, it can, even though it doesn't look so, like it's a little bit more benign than other problems, it can cause your life, right? So we have the Murphy sign. Clients take deep breaths and palpate the right subcostal area if the client has extreme pain and stops breathing on inspiration. So I mentioned Murphy and I said it was the pancreas, but I was wrong. I apologize. It's the gallbladder that causes the Murphy sign. So Murphy sign is there. We also will see some jaundice. We probably will see that as well. What else? Yes. So what kinds of medications are we giving them? Antiemetics. Yes. And we might do the G-tube. Let's see. It might be a one-day surgery where they remove the gallbladder. What's the term? It's there. So cholecystitis, right? Or for cholecystitis, we would do cholecystectomy. So they take it out, right? Let's see what else. Now here's the pancreas. So what's the biggest thing to think about with the pancreas? Like, how do we know that a person has the pancreatic pain? It's where it is, right? And it radiates to the back. They might have distension, right? They could also have the steatorrhea, right? The bulky, pale, foul-smelling stool. Let's see. What else? So what is an ominous, like what is a bad sign if we know a person came with pancreatic pain, like, and they all of a sudden, like, what would signal us that, oh my gosh, they need to go to the emergency room right now? The pain goes away. Yeah, what did that mean? What does that mean if the pain goes away? It ruptured, yes. So the pressure of the swelling, and it relieves. But then that's like a perforation. Now the products, the bleeding now is in the stomach. Now that's where now it's more intensified the pain. And they usually tell you what posture is a person usually in that tells you? Fetal, right? They're usually in a fetal position. And then what's the other thing that in the assessment that we do? It's called rebound, right? Rebound tenderness. Yes, so you press, and when you let go, the pain is worse because it bounced back and it hurts. Yeah? Mm-hmm. All right. Okay, so here's the difference between the ileostomy, colostomy, and we mentioned, so the colostomy is further down, firmer stool. Ileostomy further up, looser stool, right? And the problems there. More on intestinal ostomies. And that is that. Okay, we have 10 minutes. Can we start something? Let's start something. I feel like we need to start something. Okay, so that's done there. Okay. So let's look at oncology. I think that's our next one, right? Is that oncology? Yes. Okay, let's look at oncology really quickly. So looking at, let's stop and then stop.